Hello all, my name is SES Abdelrahman and today I'm going to be talking to you about health and socioeconomic status, its meaning, understanding, and effects on social welfare. In the past 20 years, we have seen a substantial increase in the number of articles appearing on socioeconomic status and health. Socioeconomic status underwent many transformations. When it first was brought about, its most frequent measure was poverty status. Individuals were characterized in terms of being either above or below the poverty line. As research progressed, models emerged that suggested the health effects of SES were not only due to adversities of poverty, but higher levels of socioeconomic status affect health and mortality and chronic disease prevalence. Social status and social standing reflects different aspects of social stratification by looking at the traditional indicators at the individual level of income, education, and occupation. And the more recent studies have been addressing pathways by which SES influences health, examining social, psychological, behavioral, and biological mechanisms. One of the strongest and most consistent predictors of a person's morbidity and mortality experience is that person's socioeconomic status. Socioeconomic status is defined as a composite measure that typically incorporates A. Economic status, measured by income, B. Social status, measured by education, and C. Work status, measured by occupation. The three indicators are interrelated, and often researchers use one of the indicators as the measure of SES. In addition, each indicator reflects different individual and societal forces associated with health and disease. Now let's look at a few examples that help explain the role of SES as it relates to health so that you'll have a better understanding. The most frequent measure of SES used in research was poverty status. Individuals were characterized as being above or below the poverty line. The effects of severe poverty on health are aided by the impact of poor nutrition, crowded and unsanitary living conditions, and inadequate medical care. Are there limitations with this model? The model assumes that increasing levels of income below the poverty line would contribute to better health. How about above the line? Above the poverty line, however, increasing income would not make a significant contribution to improved health status. In addition, this type of analysis underestimates the effects of SES on biological outcomes because there is evidence that the association of SES and health occurs at every level of the socioeconomic status hierarchy and not simply below the poverty line. Income and mortality. A study by Wilkinson reported in 1992 that income distribution is strongly related to life expectancy, with longer life expectancy associated with greater proportion of income. What we know is that low-income Americans are generally in poor health and have higher rates of chronic disease and disability than those with higher incomes. They are also much more likely to lack health insurance. Income inequality has shown that the distribution of income within areas, be they countries, states, or cities, is associated with mortality. How is income associated with health and disease? Income reflects spending power, housing, diet, and medical care. There are 3 points to state. Populations living in areas with greater income inequality, mainly where many minorities reside, have shorter life expectancy. Taking it a little further, other studies have shown that the socioeconomic status characteristics of neighborhoods in which individuals are living, example, average income of residents, percent unemployed, and residents in poverty area, predicts morbidity and mortality. Access to health care and the quality of treatment for minorities may help explain this part of discrepancy in health and well-being. For example, a U.S. government report stated that inner-city poor people, including minorities, often had difficulty gaining access to treatment and that hospitals serving low-income people have limited resources and generally can't provide the standard of care that mainstream hospitals receive. Lack of income leads to lack of insurance, which contributes to increases in morbidity and mortality. This means higher healthcare costs and more dependency on social welfare programs. Those least likely to be insured are young adults, African Americans, and Hispanics. Years of education and mortality. A second socioeconomic status health gradient is years of education and mortality. Years of education is recorded as the highest number of years of schooling completed or attained. Kitagawa and Hauser in 1973 found a graded relationship between mortality and years of education. In the U.S., a ratio was observed to expected deaths within subgroups among white men, depending on their education attainment, determined their risk of mortality. In brief, as the above table indicates, the more years of education, the lower is the ratio of observed to expected deaths. Are there any limitations with education? Education is available for all individuals regardless of employment status, thus it has reliability and validity. However, there are limitations to using education as a sole indicator of SES because it masks important changes in individual circumstances. How is education associated with health and disease? Education indicates skills requisite for acquiring positive social, psychological, and economic resources. Education may protect against disease by influencing lifestyle behaviors, problem-solving abilities, and values. Its impact on social welfare include positive attitudes about health, access to preventive health services, membership in peer groups that promote the adoption of continuation of positive health behaviors, and higher self-esteem and efficacy. This in turn would relieve burden of social welfare programs because individuals are becoming more self-reliant and less dependent on these programs. Occupation level and mortality. The most notable of socioeconomic status health gradients, a gradient that runs from the top to bottom of the socioeconomic spectrum, is the Whitehall study. The British Civil Service has ranked grades of employment. The lowest grade consists of unskilled workers. The next lowest consists of clerical workers, followed by professional and executive levels up to the top administrators. The study found that over a 10-year period, the risk of mortality significantly increased as employment grade decreased. What makes this most striking is that all enrolled shared employment in the civil service and had access to nationalized health care. How is occupation associated with health and disease? Occupation measures prestige, responsibility, physical activity, and work exposures. For example, physical activity has a direct association with health outcomes. According to a Whitehall II study, those at lower employment grades were significantly more likely to report getting no moderate to vigorous exercise, thus increasing their chances of getting cardiovascular risk factors such as hypertension. Another example is those working blue-collar jobs, any job associated with manual labor, are at an increased risk for type 2 diabetes than those working white-collar jobs. Blue-collar workers are more likely to work longer hours under hazardous conditions with minimal financial compensation compared with white-collar workers. If white-collar workers became healthier than the blue-collar worker group over time, association between blue-collar work and diabetes incidence would increase. A third example is presented by Fujishiro, who stated that higher occupational prestige was associated with lower odds of reporting poor, fair, self-rated health. That is because these individuals have more frequent or more significant opportunities to influence the events of their lives compared to those at lower job grades. The concept of individual control might be a variable that could lower morbidity and mortality. The relationship between prevalence of chronic disease and SES shows a linear gradient. At each higher level of SES, prevalence of chronic disease decreases. For example, the prevalence of osteoarthritis, hypertension, cervical cancer, or any other chronic disease drops as socioeconomic status becomes higher. In addition, risk factors of diseases show a linear relationship with socioeconomic status. That's rates of smoking, cholesterol levels, and sedentary lifestyles are lower as one goes higher on the SES hierarchy. If you could compare the levels of educational attainment with disease course and prevalence, we would get the same SES health gradient. For example, among a group of patients with rheumatoid arthritis, Pincus and Callahan found that the lower a patient's educational level, the greater was the chance of mortality or major decline in functional capacity. In drawing conclusions, socioeconomic status is consistently associated with health outcomes. The more we can infer about SES and its impact on individuals, the more we can concur about SES and society as a whole. This would eventually help narrow the gap of health disparity between different populations and subgroups within populations, because the various causes of health disparity work together to negatively impact morbidity and mortality rates, quality of life, and overall contribution to society.